So I will talk about diabetic foot ulcers today. This is the general surgical perspective mainly, right? And why I selected this topic is, in fact, we see, as Dr. Asela mentioned earlier, we come across this problem very frequently, right? And also, this is something usually we don't put our emphasis on, right? So those are the reasons why I selected this topic. And I will mainly focus on some practical aspects when it comes to see patients with diabetic foot ulcers, rather than going into deep pathophysiology and theory aspects. But during this talk, you can ask any questions, or we can have a discussion at the end. So this is the outline of this talk. And moving on to the introduction. So what is a foot ulcer in a diabetic patient? So any breach of the skin is a ulcer, right? So why we should talk about this? Because data shows, if in a patient with diabetes, lifetime risk of having ulcer may be high as 35%, right? So I'll just tell you, this data is mainly from West, mainly from USA, because we don't have solid data from our country. But the burden may be higher in our setup, right? Because we don't have data. So this is what is available at the moment. And the other thing, so I'm just highlighting the fact that why we should focus our emphasis on this problem. If you take 5 patients with diabetic foot ulcers, one will have some kind of amputation during the course, right? So 20% may require amputation if you see ulcer. So slowly they are progressing towards amputation. And in the United States, 2/3 of non-traumatic amputations are because of diabetes. Moving further, we see a lot of patients with diabetes admitted to, so this is called morbidity, right? So 25% of morbidity of the diabetes is due to ulcers or complication of ulcers. And the other thing I want to highlight is recurrence, right? So this gives you 2 messages. One is, if you get ulcer, they'll have very high risk of having ulcer even there's a healing. So roughly we can say it's about 50% at 5 years, right? So, but going into figures, about 40% at 1 year, and 66% at 3 years, and 75% of them will have a recurrence if you follow up them for 5 years. So that is a significant figure, because we think this is cured. So it is not really cured. So therefore we need continuous assessment and follow up of these patients. Mortality, so it says 30 to 50%. Do you know what is the significance of that? Why any significance? Any idea? Because usually we talk about mortality in cancers, right? So what is the highest cancer mortality in terms of, if you take 5 years survival, what will have the worst? What are the cancers which will have worst outcome? 3 cancers. It's a pancreas, right? So pancreas, esophagus, and so those are the cancers which will have worse prognosis, right? But if you take diabetes, a patient with diabetic foot ulcer, if you evaluate their mortality, so it's even only second to those 2. If you take colon and breast cancers, they'll have better prognosis in terms of 5 year survival, right? Because this is the hidden problem. Because they don't die with the ulcer, they die with the other complications related to ulcer. And so therefore if you take the mortality, it's in the range of these highest cancers, right? So that's why we have to focus on these problems, right? Moving into the mechanism of ulcers, I will not go into pathophysiology, just touching about this mechanism. Usually it's a combination of factors, right? There'll be, you all know the basics. Then there are neuropathy and peripheral arterial disease restricting blood flow, and poor foot care practices. So combination of these will lead to the initial event of ulcers. But the point I want to highlight is, usually the initiating event is potentially preventable. So the fact I want to highlight here is, if you can prevent a diabetic ulcer, that's the best thing. And you see, if you have ulcer, it's a never-ending story, right? So 75% of them will have a recurrence within 5 years. So best thing is prevention, and if we can prevent ulcers, I don't have to do the stroke care, right? So basically, we can stop the problem then and there, right? So that's the severity. So you have to, because we as general surgeons, we see these patients at the midpoint of their journey towards amputation, right? Usually, you all might see them in community, right? Maybe in your practices. So whatever the area you are practicing in, you might come across these patients, maybe your relatives, your parents, your neighbors, or in your general practice, right? So that's the point. You should identify them and move them towards a preventive pathway, right? Because once there's that's what I want to highlight here, right? Again, risk factors. If you read, there'll be a lot of risk factors, right? So foot ulcers and previous amputation, I talk about that. Then poor glycemic control, right? Peripheral neuropathy and arterial disease, foot deformities, skin and poor eyesight, smoking. So all are these are the few risk factors, right? Then we'll move on to if you see a ulcer, what are the things we should look for? So now diabetic patient coming with a foot ulcer, there's a wound in the foot. So what are the things we have to look for? First, you have to check whether it's infected or not, right? So I will go into detail in a while. So whether there's erythema, vomat, so you know the signs of infection, right? Basic signs of infection. And then the other part you have to explore is whether there's whether the infection is going into the bone or not, right? Because usually these ulcers occur in the lower extremities or pressure areas, and it could be very minimal outside, but the track could be going into the bone, right? You could see the bone, or there's something called probing into the bone. You can, with a hard object, you can just probe the wound and see whether you can feel the bone. Or if you do the investigation, they'll have high ESR and CRP without significant cellulitis or in terms of infection around. Right? So what are the images you would take? Usually, X-ray is a good imaging. These are baselines I'm telling, right? So it will show sometimes if there's soft tissue infection, but of course there will be other evidence of soft tissue infection in clinical examination, right? Rather than detecting a soft tissue infection in X-ray. Foreign body and features of osteomyelitis, right? But the fact I want to highlight is the osteomyelitic changes may be a late sign in X-ray. It will take few weeks to develop osteomyelitis, but of course, patient can have clinical osteomyelitis before it appears in the X-ray. So X-ray, negative X-ray doesn't mean that there's no osteomyelitis, right? Then again, arterial disease, this is a must. So any patient with diabetic foot, one of the first thing you have to check is the pulse, right? And so you should know how to check the foot pulses, dorsalis pedis and posterior tibia. I'm not joking. So few months back we had a finally exam, right? So the question we ask is how to elicit the dorsalis pedis pulse, right, and the posterior tibial pulse, the surface marking. So it's very unpleasant to see the performance, right? So it's a very basic thing everybody should do. They are medical students, so you should know how to check your posterior tibial and dorsalis pedis pulses, right? And then if there's no pulse, you can go for what is called ABP, ankle brachial pressure index. I will not go into highlight details of doing it. You can always read and see a video, right? Then I don't know whether you can see this. This is just a we call comprehensive foot examination. The things you should examine in a foot if you see a patient with diabetes, right? So there are a lot of what do you call the criteria to look for. So one thing is infection. You have to check the skin condition, right? Dermatological condition, the skin status. Then musculoskeletal and neurological assessment. Again, you have to perform a neurology assessment, because the one common reason for having foot ulcers is they have neuropathy, right? So they walk on barefoot, they can't feel, they walk on hot surfaces, and they acquire injuries, and that's the initial event which is commonly preventable. Then, as I told you, the vascular assessment, right? Then there are various classifications if you see ulcer. So why there are classification? So these are some examples of classification. If you search, there are so many classification, right? So what is the relevance of classification? Anybody? There's something called GCS, again another kind of classification, right? What is is it important in management of patients adhering classifications? Why? To get the matters complicated. Then why? Yes, one is we can standardize, right? So so GCS everybody knows, right? So I will tell if it is GCS 3 or GCS 5, to me Nuwaraeliya is the same GCS 5 for if I am communicating with somebody in neurosurgical here, it's same GCS, right? You get the point, right? So we all talk the same language, so it's easy communication, right? So that is one example of one use of classifications, any classification, not relevant to this diabetic foot, any classification, right? Another example is, imagine now patient come into a clinic with GCS 8 and next visit is GCS 9. So we talk the same language. We can monitor the patients, right? So that is the other practical point of a classification. Same as for ulcers. So if you see ulcer, if we think the usually sometimes we transfer this patient. When you transfer, if you say this Wi-Fi classification, this is the Wi-Fi, or this is the Wagner classification 3 wound. So we know what we are talking about, rather than telling there's some erythema, bit of deep wound, bit cellulitis here and there, bit of a necrosis. So that necrosis to me would be different from other person, right? But if we adhere to a classification, it's the same. So one is for referrals and is a communication, documentation, and to assess the response. So those are the importance of adhering to classification. So and one classification will not fulfill everything, right? So if you take if you assess the severity of pancreatitis, we have about 10 classification, right? The reason is none is ideal, right? So you have to select a classification according to your purpose. If you are going to monitor patients, you should select a classification according to that. If you are going to do a research or something, again the same, right? So you can refer and check what the other people have done. So and you can select one accordingly. So this is one simple classification called Wagner classification, right? So there are 5 grades, starting from high risk foot. Grade 1 means bit of erythema. Grade 2 deep ulcer but not going into the bone, right? And 3 with ulcer, maybe with osteomyelitis. 4 is gangrene, and 5 is extensive gangrene involving the whole foot. So it's a very simple classification. So I'm just giving an example, right? So if you want, you can adhere the common classification. And that Wi-Fi classification is the one which commonly used by the vascular team, right? Vascular. They talk about wound, ischemia, and foot infection. You can read about that, right? So this is example of a diabetic wound. I will go through that later. Okay, so now moving to some pictures, right? So these are the real patients I see in my unit, right? I don't know the image is clear. I hope you can see. What can you see? Is this a normal foot or any problem? Is it normal? I'm sure you have seen this kind of patients, right? Patient might come with other problems. Maybe usually they come with urosepsis, right? So uncontrolled urosepsis, so uncontrolled diabetes. But if you look at the foot, it's like this. What do you see here? Is it normal? So first thing you see, the skin is very dry, right? And the toes, is it normal? Yeah, it's not normal, right? So there are some deformities, right? And when you see the others, and nails, how about the nail hygiene? Which is not to expect to see, right? And if you see the other side, so this is what you see, what we saw. I think you can see. So the you can appreciate the tips of the toes, right? Mainly the second and third in the right foot, right? There are some ulcers, right? So what is the problem here? So patient has what is called the cloving of her toes, right? So they can't extend the toes properly, and when they walk, always this part will hit on the ground, right? And when they walk on these parts, they will have pressure ulcers, right? So this patient must have had this problem for a while, right? And hopefully somebody has seen it before, right? So that's the point you should intervene. You have to do something to prevent this point repeatedly getting a trauma, right? And we'll see what we can do. So these are the things. I mean, it's sometimes the changes are very subtle, right? So you have to inspect properly, right? That's the point. And this is another patient. So what is the abnormality here? Is it normal, or where's the abnormality? So what's happening in this big toe, right? Big toe. Is it normal? Yeah, it's swollen, right? And compared to the other toe, so is it swollen, right? And if you see the other side, so what's there? There's a tiny wound at the tip. Can you see? And the second toe, there's again another wound, right? So what is this appearance called? This is the classic appearance of for medical students. What is the spot diagnosis here? So this is the macroscopic appearance. So you see the features, it's swollen, right? And it's like a sausage shape, right? And square shaped toe. There's ulcer, little ulcer. And this is, until proven otherwise, the classic appearance of a osteomyelitic toe, right? So by looking at this, you see this osteomyelitis, right? And you take X-ray, and this is what you see, right? So you should know how to diagnose osteomyelitis, especially in toe, in lower limb toes, right? So they become square shape and like a sausage, right? And swollen, especially big toe. So this is the classic appearance of osteomyelitic toe, right? That wound might not very visible. So then you take X-ray. There's features of involvement of the bone, right? Okay. So moving into the management overview. So you should give a classification. If somebody asks you a question, you have to give a classification. So what are I am going to tell you the overview of the management, right? So you have to assess the patient. What are the other problems? What are the other complications? The patient assessment, right? Number one. And then you focus to ulcer. You don't go to the ulcer first, you assess the patient. Then you move to ulcer management, right? And in the ulcer management, there are four main components of ulcer management. There's wound debris, about dressings, and offloading, right? So that's the word you should remember, right? Offloading and revascularization. So those are the four components. We'll go into detail about ulcer. And then, of course, this is a never-ending story. If you see ulcer, prevention of recurrent, right? So those are the components you have to address. If you're writing an answer or something, then these are the components you have to highlight, right? But of course, you should apply that to patients as well, right? When you see patients, these are the components. You have not only deciding on a dressing, or we put Metrogel and send the patient home. So that should not be the way, right? Okay, patient assessment, I'm not going into detail. I'm just again giving some highlights, some points. Of course, you have to optimize the medical conditions and control the infection, cellulitis. Then again, I'm repeating this, peripheral arterial disease and bony deformities, right? So we'll see what we can do. And then you move into ulcer, right? What are the things in the ulcer? Usually, by looking at this, I told you about classifications as well. So either you can put a classification, you can put these ulcers into four components, right? There could be four types of ulcers. They could be non-infected, infected, and ischemic, and infected and ischemic, right? So non-infected ulcers, so we classify them according to infection plus ischemia, combination of both factors. These are some rough rules. If it is non-infected, then do the surgical debridement and offloading, right? We'll see what we can do for offloading. And infected, of course, they need antibiotics and surgical debridement. Ischemic, again, proper local care and revascularization, right? Again, infected and ischemic is the worst combination. First surgical control and then decide on revascularization, right? Okay, so ulcer management, again, now we're moving to the ulcer. Regarding the debridement, usually surgical debridement is the best one, right? So surgical debridement is preferred, sharp debridement, right? If you can do a sharp debridement, that is preferred. And but there are other options going for autolytic debridement and like hydrogel, right? Gel forms. But remember, surgical debridement is better, right? Just a moment, I lost my slides here. Yeah. Okay, this is an example of a surgical debridement. This patient came to me with a uh, so it's not a pleasant story. So patient had almost necrotic toe, and patient had been having dressings for this necrotic toe for a few weeks in the institute. So they are putting continuous dressings, but the toe is always hanging from the skin, right? And patient was septic. He's about early 60s, uncontrolled diabetes, and so at first go we have to do a amputation, right? And these are the steps we did. So amputation, and then I don't have a picture of the presentation. So the first one shows the during the surgery, and at the end, so we had to achieve a completely. So the principle of debridement is, so you have to remove all the necrotic tissue. The non-viable tissue should come out, right? And the other principle is usually if you're doing an incision or drainage, IND, called IND, never afraid to incise, but don't excise too much, right? So you can put incision. Incision means you put an incision. Excision means you have to excise. So here we have done both. We have to excise a significant amount, all the non-vital tissue, but excision should be done carefully, right? So you have to. That's why sometimes you do autolytic debridement to prevent unnecessary excision, right? So autolytic, the enzymes will go there. All right, it's not shared. Yeah. One moment, right? Share. I hope now you can see. Sorry for the technical delay. So that is about the surgical debridement, right? So principle is you have to remove all the necrotic tissue, and at first go, right? Yeah. So then about dressings. Dressings again. So there are some principles of, there are about thousands of dressings, right? There are some principles. Again, it depends on the ulcer base and the characteristic of the ulcer, right? After your wound debridement, or if it is a first wound, again depending on the wound character, right? So the aim of putting a dressing is to keep the wound clean and moist, but free of excess fluid, right? So the environment we need for healing is called we need the optimal moisture, right? It should not be too dry or too wet, right? So the aim of the dressing is to achieve a proper moist level for the optimal wound healing. Then role of negative pressure therapy again. So that is called vac in simple terms. So vacuum therapy again, there's a role, but to apply a vac, the principle is there shouldn't be any necrotic tissue or infection, right? So it should be infection-free wound to enhance healing by a vac, right? So sometimes it's not a option at the first go. This is about the dressing, ideal dressing. So one of the question from medical students, right? Again and again. So there are about 20 features of ideal dressing. Again, the ideal dressing is it's not existing, right? So there are dressings with combination of these features. So it could be optimal moisture at the wound level, eco-friendly, should not be painful to the patient, cost-effective, right? Odor-free. If there's an antibacterial action, better, right? So there are combination of these factors in each type of dressing, and in commercial available dressings as well. So you have to decide which one is suitable for this one, right? As a principle, if the wound is too dry, then we put a bit of a colloid or kind of something to keep the fluid in the wound, right? So like cavity filling dressing or bit of a colloid, right? Then if the wound is too wet, then you have to remove the excess wet. So we put some bit of a foam or kind of absorbent kind of dressing to those kind of wounds, right? Yeah, so these are the examples of wound dressings. There are hundreds of dressings, hydrocolloids, gels, iodine, silver. We use honey sometimes, right? I will not go into detail of these commercial names, but yeah. So now I'm just going through the what happened to this wound, right? So this is the first after the first dressing, and this is what it looked like after a few days. So again, edges have become necrotic, right? Edges become necrotic, and of course you can see the foot is swollen, right? So it's very difficult to feel the pulses. And we did arterial duplex, which shows very good flow. And at that, after the first patient was on inotropes. Now the inotropes of patient is becoming renal functions also impaired, right? At presentation, so the patient's heart was falling and the kidneys are failing, right? Now he's bit recovering. Again, we had to do a limited excision of the necrotic tissue, right? Then moving to dressing. So we put various dressings, and you see a lot of bit of exudate at the end, right? So exudate, we put bit of a papain dressing. So we use it with the this papaya. So we can use a papaya peel, and it has a bit of a enzyme autolytic function, right? What we wanted was to prevent going in and doing unnecessary wound debridement. So we did a bit of this dressing, and where the bone was there, you can see the exposed bone, right? On top of the bone, we put colloid dressing, and this was every other day dressings. And so after a few days, we see some granulation tissue appearing, and wound is slowly, the bone is also slowly getting covered with this thing. So this patient had all this dressings at home, and he had a good support. His son was applying these dressings, and he's sending pictures, sending me pictures daily, right? So at each dressing, that's how I got these pictures. Then, so this is after a few weeks, right? Now it's granulating. You see again, now we change the dressing. Now no papaya, nothing. So just we applying bit of a because it was very oozing, and bit of powder dressing, right? Without putting too much moisture into the wound. And then after a few weeks, it came up to I thought at some point we might have to do a skin graft, right? So to cover this defect, but we keep on continuing dressings, and then ultimately it healed, right? So it came to so this was the last time, right? But this took almost 2 months, right? More than 2 months for this whole purpose. And so during this time, so so that's how we managed. And he came to the hospital only once, right? For the initial wound debridement, then we discharged him. He came for a follow-up. Then everything was done at home, right? Then yeah. So what is the allowable time for primary healing? So you should have a rough idea. So to assess the progress, right? Primary healing. Usually, we think that our surface area should decrease in size 1 to 2% per day, right? And at least if you see the ulcer, that is again another advantage of using adhering to classification, right? So by 4 weeks, there should be at least 40 to 55% surface area reduction of the ulcer. So there should be some evidence of healing, right? So the why you should know these things is if there's no satisfactory progress, if it is the same, then you have to revisit. You have to relook and what's happening. So so something is wrong, right? So some patient medical condition might we haven't optimized properly, and nutrition status. So those things we have to revisit and see what's happening, right? If there is no adequate or if there's no satisfactory progress of healing. Yeah. So this is the other point I want you to highlight. So you have to remember the wound healing. It's not only dressings, right? So you have to optimize the patient's mainly the nutrition status, right? So for that particular patient, we did so he was on a high protein diet, right? So the diet was completely modified and his CBS was controlled, and throughout he was on a high protein diet, right? And of course with supplements. So the hemoglobin should be optimized, the iron we have to supplement, and albumin, and especially the micronutrients, especially zinc, right? So if you see a chronic wound, usually in my ward, I mean my house officers, they have to do three things. In a chronic wound, they should tell me the creatinine level, hemoglobin, and albumin of any patient with ulcer, chronic ulcer. So those are the areas we can usually we can modify and we can intervene, right? So especially chronic wounds, albumin is a must. You have to look for the albumin levels, right? You know, as a colorectal surgeon, we look for albumin always. If you're doing a bowel anesthesia, it should be 35, right? So same as for this wound healing, there should be optimal albumin level. If it is low, you should not supply albumin, but you have to optimize with nutrition. That is the message. Then we'll come to the other important topics, what is called offloading, right? So when it comes to diabetic foot management of foot ulcer, so surgeons we are doing this the surgical debridement, but after that it's the offloading which will heal this ulcer, right? So that is the point you have to highlight. There are various ways of doing offloading. So these are some commercially available ones as well, total contact casts. So these are some names I'll show you. So they call total contact cast, right? So the aim of what is the aim of offloading, especially for the foot? So if there's ulcer, if the patient is walking on that ulcer, it will never going to heal, right? So basically you have to remove this excess pressure eliciting on this ulcer, right? So that is called offloading. So you take off this pressure on the ulcer. So these are some commercial prepared things, but I will show you a few things. The important point is this: everything depends on the ulcer location, and the same offloading will not fit for each and every patient. So it's different from patient to patient, and that's why you have to think and do something for the offloading, right? So these are commercially available ones. So we can do what is called total contact cast. Again, these are sometimes you might have to put POPs, right? If it is a non-infected wound but need healing, but somehow you have to avoid putting pressure on these wounds, right? So this again, when you are putting dressings, especially for the foot, you have to avoid toes should be individually dressed, right? So there should you have to put some dressings individually into toes. Otherwise, if you put all toes together and put a dressing, the moistures will accumulate there, and they'll have a fungal infection in couple of weeks. So asking for trouble. So therefore, proper foot care and hygiene is a must, right? And the other thing is, you might see in diabetic patients this fungal infection in between these toes, right? How do you treat them? What is the practical advice you should tell them? Because it's very common, right? And usually that is the culprit of a cellulitis. So patient comes with cellulitis, and if you see the toes, there's an infection, you treat them, you send them home. Couple of weeks, again they are coming. So it's a recurrent cellulitis. You might think it is prophylaxis, right? But the problem is just close by, right? So you have to keep them dry, right? The practical advice usually we used to give is so they have to basically they should look after their foot like their face, right? Basically, right? So same care. You have to clean them properly, and then usually what I advise is they have to keep some gauze soaps at the tip of their toes, right? In the toes. So then you can keep them apart like this, right? And put it in front of a fan and dry them for 20 minutes, right? So in Nuwaraeliya, we ask them to use their hair dryers, right? They don't have fans sometimes, right? So for 20 minutes, they have to dry their toes. And then usually we give antifungal solution, not a cream, a solution, and apply the solution. And they have to keep it applying for at least 4 months, or usually 6 weeks. And after you seeing the complete disappearance of this macroscopic fungal infection, but you have to apply it for another few weeks to have a complete cure, right? So you dry it, wash it, dry it properly with keep the toes apart, dry it with a fan, apply this for 1 month, right? Otherwise, they will come back again and again. You have to sit with them and educate them properly. So this is again we call insole. Again, these are very commercially available. These are available in pharmacies, especially for the foot. Right? We see a lot of callosities. Right? We saw callosities, and again callosities occurs because of the maldistribution of the pressure. And sometimes we tend to excise callosities. Again, we excise them and they walk on the wound. It will not heal, right? And if it is especially a diabetic foot, you ask him for, you are making a wound, right? So the best treatment for callosities is again, we do what called shaving. You shave these prominent parts and offload them. And you have to advise them because it's not something like you do exercise and next day it's gone. So offloading it, they have to apply continuously, adhering to this practice for some time, right? So that is the problem. Patient, the compliance is, you have to advise them properly to have the better compliance. So that's where insole helping, right? To avoid the pressure on the foot. So then sometimes you might see various kind of ulcers in the foot. So this is a diagram just to show you can decide on the offloading method by yourself, right? Using what available resources, right? So you apply get a normal sole, make a hole where the wound is, avoid pressure on that site, right? And it should not touch the ground, of course, right? So these are various ways of see again some custom ways of customizing this offloading technique according to the patient foot and the degree of deformities, right? So various forms, and sometimes another common thing you can do if there's a wound is in the foot, if the patient is walking, we put two ghost rolls, right? So you apply the dressing and put two ghost rolls on the foot, right? If the wound is somewhere in there, you put two ghost roll or 2 or 3 and apply dressing. Now the patient is walking on this ghost and the wound is not touching the ground, right? So those are some ways you can invent. You have to think and do that. Again, protective shoes, right? That is also vital. All these patients should have a nicely fitting protective shoes to prevent recurrent injuries. Otherwise, it will be a never-ending story, right? And these are again commercially available, and patients have to purchase. They can come to these workshops in the hospital, and they will modify it according to their foot deformities. But the thing you have to do, you have to continuously evaluate. Imagine if you given a foot shoe, the protective shoes now, in patient coming in 1 year, and if the patient is continuously using this for entire 1 year, there might be changes, right? The foot plus the shoes. So you have to continuously evaluate and check whether still these are fitting or need some adjustment, right? These are not lifelong, they can't use them like for life. So this is again, I'll show you some stuff we can do. This is this is in literature. So sometimes you achieve nicely proper debrimo and you can go for grafting to cover the tissue defect, right? So here you have seen they have done a bit of a kind of tissue bridging and grafting on the sole, and this patient needs continuous offloading, right? If the patient thinks now everything is completely okay and walk on the barefoot, in a few weeks time the graft gone, right? Because it's the kind of skin graft, and which is not the ideal skin we expect to have in the foot. This is to have a tissue cover, but you have to advise the patient, because that's what happened with our patients. We think that surgery is done, everything is okay, back to normal life, again coming with the same problem in a more severe status, right? Okay, so I'm highlighting this recurrence rate here. So 75% at 5 years, right? So therefore the term we use this is like other illness should be, it's called remission, right? So diabetic foot ulcers are in remission now, right? So they can recur if they follow up, and if anything goes wrong, they will recur, right? And slowly heading to amputation. So I haven't talked because sometimes you have to start with amputation, what we did for that patient, the toe, right? So to prevent that is what is called the term used is preventive foot care. These are the things you have to advise, right? Of course, they have to stop smoking. It's not only for ulcers; it's good for in general, right? And they should. You have to ask them to avoid going barefoot, even at home. So usually in these patients, they don't mobilize well. So Most of the time they spend time at their home, and they acquire the injuries at home, right? Therefore, they think the home is safe environment, of course, which is not. So avoid going barefoot even at home. They have to use some kind of protective wear, right? And then test water temperature before hot bath, especially in where I work. Usually, if it is really hot, and they have neuropathy, they can't check. And it could be boiling hot, and they can put their foot nicely, and they'll be there. Next day, they'll come with a full thickness burn. So somebody else should check the water. So these are some practical points, right? And usually we don't have we don't spend time explaining these things to the patients, right? But ultimately they will come with these are the culprits. Then again, trimming nails, we call nail hygiene, right? And remove sharp edges. And usually these patients, the eyesight is not good, so somebody else should attend to that and do it properly, right? So you have to check your feet daily. Some people advise to use a mirror even, right? And of course, somebody else should do that. Then snugly, nicely fitting shoes, as we shoes and socks, right? And if you are using socks, you have to change them daily. So those are the practical things. You think it's very simple, but those are the usual initial event of ulcer, which will go on and ultimately end up in an amputation. So moving into the summary, so we discussed about the risk factors and treating infection. Again, infection I didn't go into highlight in detail, but usually about infection, we start strong antibiotics, broad spectrum antibiotics if the patient is septic, and we always refer to microbiology. We get the microbiology opinion, and according to the local microbiology policy, you can start, right? You can escalate, right? Usually we go for a bit of a, if the patient is septic and in septic, so like PIP test or something, some kind of which cover both anaerobics and aerobic, right? So gram negative cover, right? Then proper surgical care. We discussed a little about wound dressings, and of course the point we have to highlight is the importance of offloading, right? Somehow you have to offload these wounds, and the one technique is not for all patients, right? So it depends. And of course, prevention of recurrence. So in medicine, usually we tell prevention is better than cure. That's one of the first things we learn at medical school. But when it comes to ulcers, diabetic ulcers, that's very relevant, right? And what are the other conditions same as this? As general surgeons, we see sometimes in diabetic patient is the pressure, so bed sores, right? So same story. So prevention is better. Once there's a bed sore, the patient will die with the bed sore. So that's the usual story, right? So same as here. If you can prevent a diabetic foot ulcer, that's the best.